Okay, I'm just going to talk a little bit about Hospice Malaysia and a bit about our partnership, how we're trying to work together with University Malaya Medical Centre to try and provide better care in the community for patients with MND. But I'm going to start very generally. There's some of our team. And as Hospice Malaysia, we actually do more than just clinical work. The core of what we do is the community work. And we travel to patients' houses to provide palliative care. There you can see Nadia and Sansan, and Nadia will be talking to you later. And we also provide education. We do that for undergraduates, so medical students, sometimes nurses do attachments, sometimes we have elective students from other universities and even from abroad. We do postgraduate education. So Carol was one of the people that spent 6 months with us, as was Shushen, and the people who are going through training for family medicine as well. And at the nursing level, the diploma for oncology nurses, and our dream is a diploma for palliative care nurses as well. And again, we also do multidisciplinary workshops, which are open to all healthcare professionals and cover a range of topics throughout the year. So we do ones on ethics, on communication skills, on pain and symptom management, and grief and bereavement, amongst others. We try and stay involved with research because we think it's really important to understand best practice in palliative care and best practice in the community, and to understand above all what it is that patients and their caregivers really want or need. To me, research has to be driven by how do we improve our service and how do we improve our care. And we do some advocacy. So we try and talk to the public about what palliative care is, how it can be helpful. And we're involved in the palliative care technical committee that looks at the palliative care strategy and development of palliative care. So quite a range of activities, but we're going to concentrate on the community palliative care side of things. You saw two of the nurses. Actually, it's a team of 11. And there you can see Raymond, our occupational therapist. And I've just left him off the list printed. I just put him as in the picture. And we have 4 doctors. We have 2 pharmacists. So patients and caregivers are supported also by our patient services. So they're the people that you have first contact with when you call in and help arrange visits, help arrange loaning equipment and so on. And they play a very important role. I think how we communicate from the start is really important. And we have people working in what we call communications, which is all about how do we provide information about what we do and how do we advocate for palliative care. At the moment, we're looking after about 500 patients across the Klang Valley, and we look after patients of all diagnoses. So it's not what your diagnosis is, but what are your needs for palliative care and how can we be useful? I thought it's helpful just to remind ourselves what palliative care is. I'm not sure with patients with motor neuron disease, how much they know about palliative care, but it's really an important part of the care of patients with motor neuron disease. So it's an approach that aims to improve the quality of life of patients and families. And that's really important. It's not just patients, it's families as well, facing problems with life-threatening illness. And by life-threatening illness, it means really any serious illness that really impacts on patients and families and affects their quality of life and is an ongoing problem and may deteriorate in the future. So we try to prevent and relieve suffering. And I think that's a really important aspect, to think about how our care needs to be proactive. We need to understand what's happening and look to the future and have plans in place. We may not be able to stop diseases progressing, but if we know what the picture looks like, we can plan, and that can give some sense of control into an area that's really very uncertain for everyone. So it means early identification, means very careful assessment, and then treatment of pain, other problems, physical, psychological, spiritual. So very comprehensive care. I thought it's helpful also to think of rehabilitative palliative care. This is a relatively new model developed by St. Christopher's Hospice in London. And I think it's a helpful way of thinking about what is the approach that we can take. And it's very much about being person-centered. It's about working together across disciplines to support patients and carers. Above all, it's supposed to be supportive and enabling. It's not doing things to people, it's asking, how can we support? How can we help everyone get through a difficult situation better? How can we empower people? And that's sometimes simply through providing good information so that people have more choice. And it's collaborative, and it's about optimizing function. So sometimes it may seem as if you're losing power, losing function, but there are many ways of optimizing function, even if you can't restore muscle power. And it's about living and everybody's business. The idea that we're all involved in the care, the caregivers, the patients, and the wider community. And it's recognizing that all of these aspects can be affected by a serious illness. And the obvious ones, it's always a cost financially. Your work is disrupted. Emotionally, it's difficult. It affects how you think about things, your spirituality. It affects your environment and so on. So very, very many aspects that can be looked at and can be areas where we can intervene to improve things. Punitha's going to talk more on what we actually do. So I'm just going to go back to the sort of basic things that the team does. And that includes assessment in the home, identifying goals of care, symptom management, and nursing care. Now that we can't do all the nursing care, but we can teach carers and caregivers how to provide nursing care and do some of the more complex wound dressings and so on. We try and provide support for the families and care at the end of life, and bereavement support afterwards. So what about the collaboration between us and University Malaya? As you can see, we work in very, very different contexts. We have a lovely leafy green building in Cheras, and Hospice Malaysia and University Malaya Medical Centre is a huge hospital. And of course, patients and caregivers need to receive care in both. So essentially, we have been looking after patients referred by University Malaya for some years, but Prof. Nortina came to us with a plan of how can we provide much better, more seamless care for patients? How can we really communicate and collaborate in a way that will help patients and caregivers to have the most time possible at home and not have unnecessary journeys to the hospital? So, and above all, the main objective was just to raise the standard of care for patients with motor neuron disease and to collaborate more closely, but also recognizing that there are skills that and knowledge on both sides, in the hospital and the community, and we can learn from each other. So specifically, I think where our skills lie are perhaps the advantage we have in seeing patients at home is to have a much more detailed understanding of precisely the environment that the patient and family need to function in, and also who's involved in the care. When you go to hospital, often it's one caregiver who may not be the person who spends all the time with the patient, who comes with the patient, and the hospital is busy, and detailed assessment is more difficult to do in that kind of environment. But the hospital can provide more access to specific interventions, so particularly for respiratory problems and feeding problems and so on, and has a multidisciplinary team with the rehab team as well. So we can all learn from them the latest in rehabilitation thinking. And the third objective was just to gain an overall better understanding of what care for patients with motor neuron disease in the community looks like. And we really want to do some research together with that. So that's the thinking behind the collaboration. I emphasize it's in its early days. We're about 6 months into it. So we need to communicate a lot to make sure that this works.
So thank you. It's wonderful to be able to share what we have been doing for the past 6 months, especially with our collaboration with and certainly share some of the challenges and benefits that we see patients who are receiving community palliative care, especially in the MND team. So I think there's been increasing awareness for the role of palliative care in patients with non-cancer. And this awareness has also included patients with neurological conditions. And we see a lot more guidelines coming up. To name a few will be the NICE guidelines, the European Federations of the Neurological Societies, and the practice parameters from the US. So all of these guidelines have highlighted the role of palliative care in caring for patients with neurological conditions, and especially also including MND patients. And just like in the benefits of palliative care, caring for patients with cancer, there are a lot of evidence showing the effectiveness of palliative care in improving quality of life and caregiver burdens in a lot of neurological conditions, such as multiple sclerosis. It's shown to improve pain and symptoms, insomnia, and identifying caregivers' needs. And certainly this is similar in patients with MND. But there are definitely some differences in the needs of patients with MND as well as other non-cancer diseases. One of the things that is different is the prognosis, because they tend to have a longer disease progression, unlike in cancer patients. So it is quite challenging when it comes to prognosticating. And there is a need to provide a longer care. So the care term becomes a bit more longer than what we are usually used to traditionally. And there is a diverse symptoms and complex disability, because as the disease progresses, we know that there are multiple disabilities that sets in either cognitively, behaviorally, or just physically, and the challenges in communicating as they lose the ability to speak. And therefore, the symptom management becomes a bit more challenging in that sense. So there's this differences sets MND care a bit more different than what we are used to in the community. And what it seems like there needs to be a long-term support for these patients in the community. And therefore, the early involvement of palliative care is uh, highlighted and is being talked about repeatedly. And so to talk a bit more about the benefits of early palliative care referral, it's been, in the olden days, the old concept is that the referrals to us is usually at end of life. And we have now moved away from, as how Dr. Sylvia has mentioned, that we no longer look at just the estimating the prognosis, but mainly looking at what are the needs. So we are definitely trying to adapt the bow tie model here and trying to integrate the care much early on from the time of diagnosis, because there are going to be needs along the line. It's just how are we going to identify them and find the trigger points for referral to palliative care. And patients and family, they do need the extra support at varying time throughout the disease progression. And because this is a long progression, they are bound to have challenges along the way. And the earlier we get to know them and we journey with them, it's much easier for us then to identify these changes that's happening. And there will be periods in between these occasions where they might be in a stable phase, where the needs might be reduced. And that's when we need the support of a multidisciplinary team to continue the support in other aspects of the care. So this is what I was saying in using the bow tie model in trying to identify where we fit in. Because often the question is, when do we refer to palliative care? When does the community support comes in? So the answer is that we need to look at the needs and what are the trigger points. So for example, in the early stage of the disease, the time of diagnosis, there is a role for us to have important discussions, especially advanced care planning, when they still have the ability to talk, because we know along the way they might lose the ability to communicate. So this is the golden opportunity for us to have those important discussions. What are their views, the values, their preference of certain intervention if they need it along the line. And throughout the care, we then identify the needs. What are the symptoms that needs to be managed? So symptom management is probably the core business, I would say, but there's a lot more other things that we do in terms of communication, caregiver support, and towards the end, of course, trying to provide end-of-life care and caring for patients in their preferred place of care. So most of them like to be at home surrounded by their loved ones, and having the community support, then it enables them to fulfill that wish. And along with that comes the bereavement support. So I would say that along this line, there are multiple trigger points where there is a need for palliative care. Is then for us to identify when would be the suitable time to involve us, but as early as possible would be the best. So the role of multidisciplinary teams. So this is something, as you know, we've been working with for the last 6 months. We used to have referrals for patients with MND, probably less than 10 in a year. And there were times where some of our nurses have not cared for a patient with MND throughout the year because it is a rare disease to begin with. And I think along now there's been awareness there's been more referrals, we get to see more patients. And we now identify that working in a multidisciplinary team has a lot of benefits rather than working in silos. So in traditional model of care, so the neurologist, for example, would provide the care of diagnosis and treatment options. And when that's done, they pass on to the rehab physician to look at the functionality. And then towards the end of life, then the palliative team comes in. So what happens with this that does not meet the multiple needs of the patients and family? So having an MDT and each specialty team plays a leading role in coordinating care for patients at the various phases of the disease. So when there is a need for a diagnosis and discussing of treatment options, then the neurologist takes the leading role. When there is a need for looking at functionality or home modification, then the rehab physician takes in the leading role. So each and every team member has a role, but it is a more coordinated care, I would say. And with our experience with is that we are able to fast track referrals to other specialties. So for example, if Nadia is seeing a patient who has issues with the NIV, we may not have the knowledge or skills to deal with that. But having the team who we can then we have direct contact with, so we are able to connect with them immediately and get the plan management and get the outcome that we want within a short period of time. So so we find that the care is seamless and the outcome is much more faster. It avoids patient needing to go to the emergency department or hospital unnecessarily. And I think above all, having an MDT is that the same professionals become involved as the disease progresses. So there is a sense of connectedness care rather than a sense of abandonment from the primary caregivers. So this is something that most patients have appreciated because there are a lot more coordination between the different caregivers. So studies around MDT. So why are we so focused about having a multidisciplinary team? Is because evidence have shown that they do improve the quality of life of patients, and in certain extent, they've seen to shown that it does improve survival for a bit. And in studies looking at cost effectiveness, especially in rare diseases like in MND, there are now evidence showing that it probably going to be cost effective because you are combining all the specialty rather than working individually. And the NICE guidelines in 2016 have recommendations similarly showing that it is a cost-effective intervention and it's strongly recommended, and that palliative care should be integrated early from the time of diagnosis. And because of the nature of the disease itself, we need to have continuous reassessment and adaptation to the changes. So communicating within the MND team, what we find useful is to have a key person within the team. So for example, Prof. Notina is the key person in our group, whereby we communicate with her as well as the other teams within the MDT, get back to her when there are issues faced by the patients or the family. And so she's the core person who coordinates the service, and so patients and family do have contact with her team as well, with her as well, whereby they can update her what are the issues, medication top up, and etc. So within the MDT, you need to have a key person where everybody goes to. And in how we communicate is that we identify each and everyone's role clearly, and discussions such as goals of care discussions and needs and issues, they are all being shared amongst the group. So we understand what is happening. Even though if we are not seeing the patient today, we know that we've been updated by Prof. Notina, because this is what's been happening, and please follow up. So we identify our role clearly, and we are able to share information across. So what we have is also a chat group. So as I say, if Nadia has seen a patient and she's able to immediately update the team what is happening here, should the patient come in, we have medication shortage. So there is real-time information sharing and discussion and management ongoing. And this is really helpful for patients. We really cut a lot of time and effort from caregivers itself. Communication is a key aspect of when we are working in a multidisciplinary team. So the approach we do in the community is similar to how we care for patients with cancer or other non-cancer. The teaching, the strategies we use are the same. So mainly we are looking at facilitating discussions or decision making and trying to be supportive. We're not there to help, but to collaborate and empower them to make decisions that matters to them, and to be patient-centered in a place that they are familiar with, in a home setting where there is no boundaries in terms of SOPs or time limit. Unlike if they were in an outpatient, there are certainly some barriers in terms of having a more in-depth discussion. So I think we have the advantage of in terms of communication in the community because the environment is just different. And of course, bereavement support, but this has been, I would say, been affected because of the pandemic. And I hope that over the next year, we are able to pick up on our bereavement support for our patients. And so this is the disease trajectory that we are all familiar with. And I believe that MND fits into the disease trajectory of patients with other organ failures, where they are, of course, functionally have already been in a declining state. There will be instances where there are emergencies or acute disabilities that affects them. Sometimes they may need to go back to the hospital for treatment. But what happens is, so why I put this up is that, again, is to highlight that at every point, there is a role for us to play in providing the care for patients in the community. And what I found the benefit of our support for patients is that it does reduce time in the hospital. It allows them to spend more time at home and indirectly increase their satisfaction, especially when they are approaching end of life. They really want to be at home. They don't want to be subjected to a lot more of interventions and just to be surrounded by their family members. Otherwise, there will be restriction because of the COVID, limited number of visitors. So a lot of that has been able to overcome if there is community support for these patients. And we are able to provide frequent follow-up. So the frequent follow-ups are important because we are able to identify the changes as it happens, what are the needs, and we are able to intervene on a timely manner. The other important thing is our out-of-hours care, so the on-call service. For some reason, emergencies always happen after office hours. So this is also an important aspect of care in the community. And I'll say that we are at the forefront of dealing with family caregiver issues and burden, because as Dr. Sylvia mentioned, is that sometimes we don't see the main caregiver in the hospital. The caregiver would be just the runner who picks up and sends the patient to the hospital. But when we are at home, that's when we see the real challenges and how they navigate between work and home and being a family caregiver and dealing with all the multiple issues of symptom management, medication. So we are able to be there to understand their needs and probably highlight these issues back to the MDT team in how can we support this patient and caregiver better. So I would think that one of the advantage of our support is that we are able to support our caregivers much better in the community. And again, it's a seamless care when we work in a multidisciplinary team because we are able to share information and constantly communicate with each other. Now, there are challenges in the community. So one of it is because the experience itself, because MND is a rare disease. I mentioned that we uh, we don't used to get a lot of referrals in the past, and so we have to learn. There is a need for us to learn additional skills like how to manage posture using equipments, learning different communication tools. These are things that we find to be specific to MND patients. And so there is a need for us to go out and look out for these. We need to learn about these things outside of what we used to do. And definitely there's insufficient resource to meet the needs because we cater for a relatively small area in Klang Valley. There is a lot of need outside of Klang Valley in itself. We just don't have the human resource or the time to provide the care. So these patients will still end up going back to the hospital if they need further care. And one of the challenges I find in the early days when I was doing my attachment in the clinic was that I find it quite challenging explaining the earlier role of palliative care to, in fact, all participations, families, and even the healthcare workers. And therefore, I guess it's good for us to look back at the previous diagram that I've shown is trying to see if there is a need for us to navigate a ACP discussion or a goals of care discussion. So often it's challenging to tell them why are we there because they're not dying yet. And because of our association with death and dying, it does affect the readiness to accept palliative care. It's still something we are working on to continuously educate our colleagues and patients and family. And as I mentioned, there's just a small proportion of patients with palliative care needs who are actually non-cancer. Only a small portion of them have access to this care. So we provide in the Klang Valley, but I'm not sure how about those living out of Klang Valley. So I guess moving forward, my experience, our team's experience is that we find there's benefit working in a multidisciplinary team, especially for patients with MND. We need to strengthen our collaboration with the hospital and the community. We need to be proactive in adapting and learning new skills and knowledge, because this is something we are not experts, but we are learning. We are sharing knowledge across disciplines. We need to advocate for the palliative care approach in MND care. There is still a lot of fear, resistance from all parties. And so the reassurance and education has to be ongoing. And I would also like to say the awareness within our palliative care community. I often hear that they find it challenging, or they find that caring for patients with MND is difficult. So I would like to say that, it's not difficult, but rather these are patients who really have a lot of needs, and they are people who might greatly benefit from our service.
So good morning. I think you have known me by three speakers before. So thank you to everyone. This morning, I'm going to talk about patients at home, which I hope by end of this session, we will be able to recognize the impact of MND to the patient, family, caregivers, and also their challenges at home, and also our role in providing the support to them. Mr. Ong is a patient that is actually referred by UMMC team, I think few months back. He is someone that always very, very active. So he worked as a salesperson. He sell reverse osmosis water, and he also has some contractor company. So he did a lot of construction job. Because of his construction work, so he did his home renovation by himself. He loved doing magic tricks. He had a lot of special classes that he attended because this is his passion, and he did actually few show for his magician technique and also the tricks. And in fact, during my visit, he showed two tricks that we can actually easily do at home or with family members. So he only stay with his wife. He lives in Rawang. He lives in a 2-story house, very spacious house. But then there's only 2 of them. So these become challenges actually. So he is progressively having lower limb weakness over the years. That has been started since 2018. But he was only diagnosed with motor neuron disease in October 2020. And eventually he became wheelchair bound and also bed bound. And recently in September, he started to have upper limb weakness and also intermittent difficulty in swallowing. He has a lot of issues at home in terms of the physical side, which at first, when we first visited him, he complains of soreness at both feet and knees, which in my first assessment and examination, I thought this is just aching pain, because most of motor neuron disease patients, they're prone to have aching sensation because they can't really move, they can't really actually change position frequently, that causing them to have aching pain. But after we started with some pain medication, tramadol, and during subsequent follow-up, the problem is actually not settled. In fact, the medication is not really giving any effect to him. So during the second visit, we try again to manage the soreness feeling. It's not painful, it's just a soreness feeling. And then we tried some anti-neuropathic agent, and magically that helps him very, very much. So he can sleep well, he can sleep better. During the uncontrolled soreness feeling happen, he actually seldom sleep well at night. So he will wake up every 30 minutes just either to massage the legs. And of course, it is also affecting the wife, which at the same time, when he had all these symptoms, wife also need to get up and also try to help him to relieve the soreness and also the aching feeling. So both of them are not really having good sleep and good rest. And at that point of time, they are unsure what to do. Do they need to go back to hospital and ask the doctor to fix this? Or can they just stay at home and getting the help from nearby GP? So when the referral made, so that's why they feel that this is the most important thing to deal with. And after the neuropathic agent started, he do feel some improvement, and eventually it is better control after 2 weeks. And he feels so much better now, and he's also able to sleep well, and wife also able to cope better. In terms of the social issue for him, as I mentioned before, they stay in a very spacious house, 2-story house, but it's just only 2 of them. They keep on having carer issue because the moment they hire private carer, it is only last them about maybe the longest is 2 weeks and the shortest is 24 hours. What will happen when the carer actually agree to come in and care for him, and the next day when both of them got up from bed, try to look for where is the carer. It's either the carer just gone, disappearing, or they will just already pack their things and then say that they cannot cope with the patient's care and decided to actually stop working. So they have been spending a lot of money because they try to get a help. Patient don't think that the wife will be able to cope alone, especially with the transferring, with his immobility, that require a lot of energy, that require a lot of attention. And of course, the wife will need another help to make things easier for herself. And patient also will not feel so burdened if, let's say, they can have extra hands to help. Because of this carer issue is ongoing and they keep on paying the private agency thousands and thousands, but then they cannot retain the person that look after the patient. It is causing a lot of carer fatigue because they will need to try again, try on, searching on, and then in the end, there's no one that is actually really wants to look after the patient. And when this happen, the wife will need to actually cope with the rest of the care, including feeding, including transferring, household, and any other things. There is one visit when I came and see the patient, they didn't even know that the carer just left. So when they opened the gate for me to come in, and they tried to call the carer, but no reply. When they opened the carer's room, actually the carer has gone, which they also not sure when actually the carer just went off without any message. So when I reached them, patient and the wife hasn't had their meal for that day. That time is around 11:30 a.m. Patient looked very sad, very distressed, and wife is tearing because they are unsure if, let's say, patient pass motion now, who can help them to transfer the patient from the wheelchair to the commode chair, or from the wheelchair to the bed later on. So at that point of time, of course, we also do not have any carer that we can suggest to them. So what we offer is actually ask the wife to have her meal while myself and another doctor is actually feed the patient and change him and do a little bit of nursing care, changing clothes, wipe him, and we make sure that the wife finish the whole meal before three of us transferring the patient back to the bed. And while waiting for a new carer to come in, that time the patient and also the wife actually agreed to get help from the neighbor, and the neighbor also luckily feel very free that day to help them in terms of transferring. And I heard recently, I think few days ago when I contacted them, they have a new caregiver, but they also not sure whether this caregiver will actually sustain for longer time or not. And of course, the other challenges that they are facing from time to time is the logistic, because they stay very far from the hospital, and usually they will need hours to prepare the patient. So let's say patient get up in the morning, they will need time to transfer him, to bathe him, to change him, and then to prepare him for the journey to the hospital. And because of the duration of the from house to the hospital, so take about 1.5 hours. So that added the time that they need to go to hospital. And because patient also using wheelchair, so they can't really use the normal car to go to the hospital. So they need to hire the mobility services. And mobility services also have their own schedule and time, which the patient and the family also need to follow. But because the appointments given to them is always 10 o'clock in the morning, so that's why every time hospital appointment, they feel very stressful because they need to actually gauge the time that they can reach there. And at the same time, they need to overcome few challenges before patient can reach the hospital. After going to hospital, another issues that they face is how to go back to home after the appointment. And that also actually take time for them to prepare the patient to transfer to the mobility services, with the journey back at home, with the aching pain that he will have along the journey and come back to home, because he will be actually sitting more than 2-3 hours on the wheelchair. So that become a lot of child stress thing that they need to overcome every time they plan to go to hospital. And of course, with a lot of payment to the carers, agencies, um, a lot of things that need to purchase to make things easier at home, to make the carer easier, they run into financial issue because we know every carer that comes in, they will need to pay thousands and thousands, but yet they are still actually changing the carer very often. So that's why they are facing financial issues in terms of getting a new carer every time. For the patient also, he feels that he has lost his role as a husband, because all this while before his sickness, he would drive the wife to run the errands, to buy household. But since patient losing both power of the lower limbs, he cannot drive anymore and he become bedbound. So now the wife need to learn how to drive at the age of 70 years old. So that's why the husband feel very sad and also frustrated with these changes. He will have the same worries every time the wife needs to go out and buy things for their household, or she needs to go and pay the errands and all that. So usually if let's say wife is not coming home within 2 hours, then he will be very, very anxious and very, very worried. But then if let's say he is calling the wife, then the wife will not be able to actually focus with the driving because she just learned how to drive. So we can imagine actually how stressful both of them, when patient actually worry about the wife, but at the same time wife also worry about him, and they always have feeling of uncertainty about tomorrow because they were not sure what challenges that will come the next day, whether maybe the carer is still there but maybe the carer will be leave, or maybe the carer is still there but carer doesn't want to do more things for the patient, or maybe they will face any other physical symptoms the next day. And at the same time, patient will have to actually think about whether he is burdening the wife, though the wife keep on saying that this is her responsibility and he really wants to care for the patient. And this is vice versa. Patient also feel like that, and the wife also feel the same way. And when this happen, they are focusing care towards the patient and how they can run their day, how they need to overcome the challenges every day. That actually causing social isolation. Previously, patient will have family members, will have friends to come in to share their good times. But since they are too busy with their own issues, the family members also stop seeing them, and they also no time to actually meet their friends anymore. So in their life, it's just them, both of them at home all the time with all the challenges that they need to face. So this is a second case about Mr. Hugh. So Mr. Hugh, he worked as a fertilizer contractor in Port Klang. He's also a very active man. He never been at home. and he is someone that will actually need to meet the client, need to meet the friends, need to meet the colleagues outside. So from the wife, being at home is because he has this illness. Otherwise, he will not be at home at all. And he's a very strong man that will be carry out the hard duty job. So that's why being bedbound, being a wheelchair bound at home, it is kind of really sadden him and make him feel very frustrated. So he lived with the wife and a maid, and also the son's family. But because the son is has his own commitment and he needs to work, so that's why the care is only focusing from the wife and also the maid. He has been having a lot of falls since 2019, 2020, that time, and he thought it was his spine problem. So in 2021, he underwent spine surgery, but the problem is the weakness never improved. It is just the same as the first time after he had the surgery. Until June this year, only he knows that he is actually having motor neuron disease. The issues that he has at home is also a lot of physical issues, which the worsening of stiffness over the months. So only this 3 to 4 weeks, this stiffness is actually causing pain to him, especially at night. So the leg can be stiffened at any time and causing pain. So that's why the current medication of like he's having baclofen dose, we try to actually change and adjust the dose at night so that he can sleep better with the less stiffness. When this happens, it is also leading for him to have insomnia because he needs to keep on changing position, and that leads to the wife also causing a lot of distress at night. And he is losing his mobility, so transferring is an issue. And at the moment, he really can't move or transfer himself at all for the past 2 weeks. So all this has actually added the worries not only to him but also to the wife. They cannot get a carer that is trained and that's specialized in caring for motor neuron disease patient, and they know the maid will not be able to cope with the transferring because the maid is also quite small size lady and the wife also the same. So to get an expert like occupational therapists or physiotherapists to come over to teach the transferring technique is also a challenge to them, because nobody is actually can do this in Klang area. So they don't offer home visit unless you go to their setting or you admit to their place, then only they can teach how to do it. But the problem is when admission, there is only one family members that allowed to be with the patient, which the patient don't feel it is safe because wife will be unable to carry him, to transfer him, and the maid will not be able to do so too. So this also lead to the financial issue because they need to actually invest in few equipments that they are also unsure how to use it. For him, he also cannot find the meaning of life because he's always out there. He always work all the time, meeting friends, meeting clients, but now he's just bedbound and housebound, which he cannot find what is it meaningful to him anymore. And emotionally, he always go to the morning market with wife every morning in the past. But then because of now he's wheelchair bound, that becomes social isolation. So people in market keep on asking where is him. But for him to go back to the morning market is impossible with the wheelchair. And wife also will not be able to cope if let's say she bring him to morning market, there's a lot of preparation need to be done. There's a lot of transferring that need to be considered. And since then, he never met any friends. It's just the close family members that will be coming over to visit him and fulfill his time. So from these two cases, we can see the common challenges that they are facing day-to-day basis. The highest, I think the most problem that we are seeing is the carer issue. And of course, this will affect the carers coping in their daily activities. There is very lack of resources in the community. Like what I said, it's so difficult to get a private carer that is trained. It's so difficult to get a physiotherapist or occupational therapist that can come over to the house and teach them the proper technique in transferring in mobility. And when this happens, it is also actually causing lack of guidance. So they are just doing what they can do with the resources that they have at home and try to maneuver and then try to actually simplify that to what they can cope at home. And all of this is actually leading to the financial constraint. When a lot of challenges that they are facing day-to-day basis, it is affecting their emotional. They will become to have a social isolation, and both of them also will have uncertainty what will happen the next day. And of course, lastly is the logistic issue. So from this research, for someone that is caring for a patient, they will have social isolation, fatigue and exhaustion, also the other factor that affect them. They also will have interrupted sleep. As what I said earlier, because of the uncontrolled symptom, they can have insomnia, and they will not feel their self is important anymore. So that's why they are having lack of self-care, and this also can lead to depression and anxiety. How we can improve the carer support? I think Dr. Punitha, Dr. Sylvia has spoken about the work that we do with University Malaya. So I think it is a good move because now we are actually referred earlier and we can be linked from the diagnosis. So we do a lot more symptom management. We do a lot more psychosocial support for patients in the community. And we will need to recognize and attend to their needs at all time. We do have the on-call services, which they can contact us at any time when they run into trouble or when they have questions to us. Respite care admission is also one of the things that we need to consider if, let's say, they have a very burnt out carer or the carer unable to cope anymore at home. And of course, for us, is the continuous evaluation of how we can improve our knowledge, upskill ourselves, so that, like myself, a nurse that maybe can be an occupational therapist, at the same time become psychologist, at the same time become a doctor to actually help them to make sure that they have a good quality of life, make sure that they feel supported at home. And of course, for the bereavement visit and also the bereavement support, I think Dr. Punitha also has spoken about this. In this research also, they talk about resilience. So we need to make sure that with our knowledge, with the information that we provide to the patient and the family members, they have some resilience in themselves for them to bounce back, to overcome and to face the challenges that they face day-to-day basis. And we need to be aware how we would like to actually ease the burden and needs by providing enough information, proactive approach. We need to control the symptom as fast as we know about it so that they will not feel so troubled. They will be able to sleep well at night. And we need to do the carer assessment timely, so we know how bad is their stress level, how good they cope with the care. And of course, we will be able to actually allocate the resources in timely manners. So in summary, I feel we as a healthcare professional need to acknowledge the impact to the patient and the family members, not only from their physical part, but also their spiritual, their emotional, and also their social issues. And we need to be aware that they are facing challenges day to day. They are facing a lot of issues that we need to actually know and then understand how to deal with it. And we need to recognize how to support them with the resources that we have and with the knowledge that we have.